Okay, this is part two of a presentation for the Hep B working group on a review of Hep B notifications. This section we're going to have a look at China and Vietnam, the cases who were born in those countries. We're going to have a quick look at Chinese and Vietnamese patient experience research and some called data quality improvement opportunities, and look at the differences in the primary care environment in Perth. So diving in on China and the Vietnam cohorts. For China, the geographical distribution for Perth Metro for the 623 notified cases. Sorry, pardon me, there are 623 notified cases with country of birth as China overall. For Metro, that's 586 cases, and we see that concentrated in the southern corridor. So the top five postcodes, 6155, 6107, 6164, 6062. And then we see 6009 coming in at number 5 with 21 cases. That's Netherlands. So I would wager that is to do with the university campus. And yeah, so we can see this southern kind of concentration around that Canning Vale area, and also up to sort of the Cannington and down towards the coast, more Success and Coburn. And then if we have a look at the age distribution for those who were born in China, we can see it skews to female, so 59% of cases female and 41% male. And this group is younger than the non-main English speaking cohort overall, with over 50% of the cases born between 1975 and 1994. We look at Vietnam. The cases with country of birth Vietnam were 370 overall for the period. In Perth Metro, that was 318. These are concentrated in the northern suburbs, around that northeastern pocket of Marangaroo, Girraween, Mirrabooka, Morley. And I've left in here, even though it's not Metro, I've left Northam, just out of interest, that I would suggest that ranking has to do with the Immigration Detention Centre. But have to look closer to find out if that disappears in different time periods. The age and gender breakdown for the Vietnamese born cohort, it is also skewed female 54%, male 46%. And this group is younger still than the non-main English speaking overall, and the born in China cohort, 56% of cases born between 1980 and 1999. Just looking side by side, just for ease, you can see the overall non-main English speaking postcode distribution, followed by China and Vietnam on the right. And so we can see that, yeah, Chinese group down in the south predominantly, Vietnamese group up in the north. Comments on the other top 5 countries of birth. The Philippines, I'm not going to get into them in this presentation, but Philippines is concentrated around the greater Cannington area, around that 6107, and with a hotspot also around Balga-Mirrabooka. For the Burmese group, that's very heavily concentrated on 6061 and 6064 in the north, a similar picture to the Vietnamese map, very much on the greater sort of Mirrabooka, Girraween area. The Malaysia cohort is concentrated southern around the 6155 Canning Vale, similar to the map for China here. And that's all that I have notes for. Side by side, looking at the age and sex breakdown, and just so you can have a look at the relative shapes there. So even more female and younger for our top 2 countries of birth than all non-main English speaking. So I also wanted to have a look at, or trying to bring in, I suppose, some consumer voice. There's a whole lot of talking here about human beings as cases, and I really value and really recognise the importance of lived experience in all of this discussion, and which is hard sometimes to be centering that. So I wanted to have a look at recent qualitative literature on chronic hepatitis B and these migrant groups. Just going to pop a few papers in here and with some kind of direct quotes from people living with chronic hep B. And this is something you can go and have a look at if you would like to later on. This is a paper from 2022 in, I believe, Sydney and Melbourne, and these are, the participants are Chinese immigrants originally from mainland China, and it was, the method was semi-structured in-depth interviews that was conducted by a researcher who also had Chinese language and background, and this was done over 2019 to 2020 with 16 people who are living with Hep B and born in China. This is some of the vignettes, and the findings were that the Hep B related stigma has mostly been driven by knowledge deficits about Hep B and fear of Hep B infection. Hep B related stigma was mostly demonstrated around social isolation, including isolation imposed by family and the community, and employment restrictions in the Chinese context were a concern. In the Australian context, Hep B related stigma was related to ethnic and cultural background of people living with chronic Hep B, and it primarily occurred as anticipated stigma in the community and in employment. And you can see some of that expressed in these quotes here. Zhao and Wallace looked also at people living with chronic Hep B who self-identified as ethnically Chinese. This is a study that looked at the population of a public hospital specialist liver clinic in Melbourne. So it's a descriptive qualitative study. The period was the 1st of September to the 30th of November 2019, again done by interviews, 30 semi-structured interviews. The recruitment was by invitation to all eligible patients who attended the clinic in that period. The number invited, so the number declined wasn't recorded. And so these are, importantly, people who are already engaged in tertiary outpatient care, and they were looking at what are the factors that enable them to stay or to engage and be retained in clinical ongoing care. Findings were that the enablers were kind of three intersecting attitudes, and that it sort of explained why these participants chose to engage in long-term clinical management. The first was the perceived seriousness of the consequences of chronic Hep B. The second was perceived benefits of attending clinical management. And the third, importantly, perceived no barrier to attending clinical management, which they explain in a little bit more detail if you want to read. 1/3 of the patients in this study were commenced and retained in regular care right from the outset after their diagnosis, and the remainder had some delayed or interrupted linkage to care. And this slide here has got some of the comments of the participants who, on the topic of their linking to care and how that came about. I'm not going to stop on this slide for long, but this is for your interest if you want to pause or come back to it. This, I thought, was a very good summary of what of that paper, of what the authors have found. They've got the beliefs that they feel determine these behaviours, what factors contribute to this belief, and what they believe the applications to be. I think for our discussions, the no barrier beliefs and the healthcare system factors are particularly salient, and something we might consider as we go along with this working group. To look at the Vietnamese community, this is a paper from published last year. It was funded by the Hepatitis Programs Unit in the Pop Health Division of New South Wales Health. This is New South Wales community eligibility with people over 18 years who identify as Vietnamese and living in New South Wales. It comprised of 20 one-to-one interviews with a Vietnamese-speaking researcher. 4 of these participants were people living with chronic Hep B, and 6 were people with loved ones living with chronic Hep B. It is a small sample size, and they struggled to recruit people living with Hep B, and they noted that the sample is sort of self-selected. And what they found in their sort of category of knowledge of Hep B, that participants who had Hep B or knew someone with it, they tended to be a lot more confident in their Hep B knowledge. They found only a few participants recognised that Hep B could be asymptomatic or invisible. Most were aware of the availability of a Hep B vaccine, many reporting that they themselves had been vaccinated. There were a few participants who weren't sure if a vaccine existed or didn't know if they had been vaccinated. So their findings around stigma that I thought were quite poignant. Over half of the participants reported that they had distanced themselves or would do from people living with hepatitis B, and all 4 of the people living with Hep B participating in the study expressed real fears or direct experiences of stigma and discrimination if they disclosed their Hep B status. So I think that really underlined for me that is still very alive and well in 2023 in our major cities. And on sources of information, a big factor was health professionals of the same background as participants. That was very valued. Aside from being able to communicate in Vietnamese, participants also felt that these health workers would be able to identify with them and understand their experiences and their difficulties of the people of cold backgrounds will face. And they also felt that online sources of information, this was preferred by younger people, and they noted the ease of accessing information in Vietnamese language when they went online. Younger people were a large, over half of the cohort, but difficulty accessing online information was noted by the older people participating, and they had preferences for traditional media, especially in language. Okay, moving on now to our weaknesses and our opportunities with cold data collection. Looking back at these 10 years of cases, we really can't ignore the incompleteness in the cold identifiers, so both in country of birth, but particularly pronounced in the preferred language identifier. We know that what gets measured gets managed, and I think that's one of the important lessons out of this exercise is around our data quality management. First, what are we collecting for the WA Notifiable Diseases database? We have the core identifiers, country of birth of person and preferred language, which we've already seen. The notification form snapshot there on the left, and this is the reporting mechanism is currently being digitised. For the National Notifiable Diseases Surveillance System, those are the minimum data that each state reports. The diseases listed there on the right and includes Indigenous status, but no other called identifiers are part of the minimum data. They only come into enhanced data for some diseases. So what is the best practice? Are we doing best practice in our cold data collection? The ABS has a set of standards for this, first established in 1992. They say that it's intended that the standards be used within and outside the ABS in all relevant data collection activities, as this will improve compatibility and comparability of data derived from different sources. The minimum core set that the ABS prescribes is on the slide there. I'll note that main language spoken at home is the key language indicator, and this is a different indicator than preferred language, and I'll talk about that a little more on the next slide. The standard set, so in addition to this minimum, the ABS prescribes a standard set which has ancestry, country birth of father, country birth of mother, first language spoken, languages spoken at home, religious affiliation, and year of arrival in Australia. And that one I've got asterisks on because that is quite a significant indicator for public health purposes and even in clinical contexts. So we had a statewide review of cold data collection back in 2018. This was done by the epidemiology branch. Dr. Sally Forrest led this work, and it recommended that the WA Health System develop its own minimum core set of cold data, and it had these 5 proposed variables that are on the slide. So it was to be country of birth of person, Indigenous status, and then main language other than English spoken at home, which was to be followed by interpreter service required and preferred language after that. So the main language would be the filter question to interpreter service, and which then prompts the preferred language. So I'm just noting here that this main language other than English spoken at home is the most important and usually the most widespread language metric if you're only going to have one. This year we've seen some exciting developments, at least in my opinion. For WebPAS, which is the primary patient master index for our public health system, which means it's used in all hospitals, outpatients, and many of the HSP specialty services, where it's considered to be the source of truth for patient information, and that feeds into other databases such as the digital medical record that's now in use at most sites. If you're in the public health system, you'll be very well familiar with WebPAS. It had existing items for country of birth, Indigenous status, and interpreter requirement, and this year's changes have added ancestry ethnicity, which can be different, of course, to country of birth, and this one allows us to have a look at second-generation migrants, for example. And then it has main languages spoken at home, plural. So they've added that best practice indicator, and they, I think, have allowed for 2 languages for sort of practical reasons around providing language services. And these, they might seem like small changes, but they are really a very big deal. It's been a long time coming and a lot of agitating for change from clinicians and others in the system. It's never as simple as it sounds to just add a box. And I think this is momentum that we can and should use. We can ride on this wave of change and to then look at making changes to cold data collection for the notifiable diseases in our state. And also this opens up possibility for data linkage down the line when we have more sophisticated and integrated information systems, but there might be the ability to pull this important demographic data from that source of truth PMI for what we do our business in the future. I also, and just finally, wanted to have a little look at what might be different around access or the environment of primary care in Perth for particularly people who are overseas born and living with chronic Hep B. This was really just born out of curiosity for me, and so I've taken a quick look at our sort of GP numbers grossly, and then at our bulk billing trends in WA and comparing that to the other jurisdictions. I think that access and affordability is quite a big part of the story for the chronic Hep B cascades of care around that engagement and retention. I think this goes to Wendy's comments that she raised in the meeting discussions. This cost of engaging in care, which is not just money, but also the cost of time and opportunity costs for people. I think this will have a big impact on 2 parts, on the retention in primary care in the first place, and it will be significant for transferring care of the low acuity patients from a tertiary setting to an tertiary outpatient setting to a primary setting. That, alongside the greater capacities for care coordination, health system navigation that exist in these outpatient settings, more than they do in GP primary care, in my observation, I think will be really significant for the work that we're trying to do. And I do think that this is reflected in the qualitative literature also. So this is figures from Department of Health and Aged Care. It's their general practice workforce data reports for 2018 to 2023. My question was, how many GPs do we have per population in Perth? For the state, overall, fewer than other states. You see it on the map there with only the ACT and the NT below us. But then you've got to ask the question, how much of this is attributable to WA's large rural remote population where we know GP access is poorer. So deeper in this data set, you can look at GP FTE per 100,000 population by different areas. So this is looking at only metropolitan areas in 2023, and this is using something called the Monash model. So the GP FTE per 100,000 for metropolitan areas, so MM1 areas in WA, was 101.7, where the national average there for MM1s was 115.2. And there I've listed the other metro areas in the table, so you can see the comparison that of the other states' MM1s compared to us. Also notably, the growth rate for GP FTE per population for WA was in decline over the preceding 5 years, declining 1.2% compared to a national MM1 growth rate decline of negative 0.4%. Noting that the NT is not listed here because it doesn't have an MM1 area. And so I think the answer to my question is that there are fewer full-time equivalent GPs per person in WA metro areas than the national average, and that the metro areas, and then the metro areas in other states by the ACT. And also, while GPs per 100,000 in metro is shrinking nationally, the decline seems to be more pronounced in WA metro. Also wanted to look at bulk billing stats, and I went first to an organisation I'd never heard of before called CleanBill, who published something called the Blue Report in January 2025. It's their third of these reports, and you might have seen it in the news. It got picked up, and it's quite a lot of reporting. So for this, they go between October 2024 and January 2025. They called every one of the 6,925 GP clinics across Australia that were in their database to update their information that they keep. They do this to maintain that their primary product is a database that consumers can go and use online to find all of the primary care services in their area and filter that out by price and see affordability. And because they do this data collection process annually, they're able to produce these reports, and that can show change in bulk billing over time. The Federal Health Minister, wasn't too excited about this report and wanted to point the public towards official figures. So we'll have a look at those next. But the report finding, it said that states like Western Australia now have one available bulk billing clinic for every 46,639 adults. So this is a snapshot from the CleanBill report. You can see WA as the lowest bulk billing rate of the mainland states. And I should point out here the way that CleanBill looks only at non-concession adults. So they call a practice and they ask, if a new patient who is an adult without concession comes to your practice tomorrow, what will you charge for a standard consultation? So we can see where we rank there. And then if we look, they also show the average out-of-pocket costs. So we can see here we are quite similar to the other states, but proportionally more of us are paying it. So official figures now. This is the Medicare bulk billing and out-of-pocket costs over time from the Australian Institute of Health and Welfare. This is a December 2024 report, and the rate here is bulk billed attendances divided by all attendances at GPs. So the bulk billing rate on their measure for WA is 84%, was 84% in 2022 and down to 71% in 2024 for all attendances. The AHW also in their 2024 Medicare bulk billing report had these trends for each state's in the out-of-pocket costs, and this is adjusted for inflation, this one, and the lines are different age groups. So we can see that out-of-pocket cost per service was trending down for all the age groups in 2023. Interesting, I think a notable spike there, or it could be argued as a correction there in the costs for 0 to 15-year-olds. Certainly that's something I've observed. My practice no longer bulk bills children, which I think is says something about the state of play. different report here. This is the Medicare statistics per patient bulk billing dashboard from Department of Health and Aged Care in August 2024. So these are official figures for the proportion of patients who are always bulk billed, sometimes bulk billed, or never bulk billed. So the dark blue, in WA, we have fewer people who are always bulk billed than the declining national average of 47.7%. And looking at the light blue group, in WA, we have more people who are never bulk billed than the national average of 14%. Also from that Medicare, the per patient bulk billing dashboard, this is now broken down by the PHNs, and so you can see a comparison of Perth North and Perth South, our capital city PHNs, to interstate city PHNs. We have the always bulk billed proportion being shown here. So it's patients who always go to the GP and don't pay an out-of-pocket, don't pay gap. So for Perth, that is Perth North, that was 34.3%. For Perth South, that was 40.8%. Both of these are trailing the national average of 47.7%. And Perth North, notably, had the lowest proportion of patients who are always bulk billed of any of the metropolitan PHNs nationally, and fewer even than Tasmania, where you often hear things are in the direst straits. So in the one sort of wooden spoon list, the bottom ranks for capital cities, we are in 1st and 5th place. So Perth North, Brisbane North, Tasmania, Northern Sydney, Perth North, and then Adelaide PHNs. This is really just for interest. I'm going to wrap up here, but when you go to the Clean Bill website, I was interested to go and have a look at my own practice and area. Basically, you can type in where you are, and it'll have a look at the costs for a standard consultation and a long consultation at your GP or the GPs in your area, and it will tell you whether that's the average price for the area or below, way below, or above. And it'll also tell you if the practice has said no new patients. So I went and had a look at our top practices, notifying practices, and we did have 2 no new patients on there. The Lung Medical Service and Dr. Pham practice both were reported as no new patients, and mostly these practices were average price for their area, and that's sort of around the $85 for a standard consultation. Only one of them, Rudlock Road Medical and Dental, that I looked at, came up as the ranking of way below average for the area, and that was $75 out of pocket. And just noting that the Medicare rebate currently for a standard consult is $42.85. So just to close out the second half, we looked at the China the cohort of patients notifications who were born in China, and this is the largest group of cases born overseas, and born overseas in non-English speaking countries. It's 18% of the non-MESC. There are more female cases than male cases here. It's 59% female. The cohort is slightly younger than the NMESC overall cohort, and it's concentrated in the southern suburbs. We looked at the Vietnam cohort, which is the second largest. They're concentrated in pockets in the northeastern suburbs. It also skewed female at only 54%, and it is younger again than the China-born cohort. We talked about there being opportunity for cold data quality improvement in our data collection processes for notifiable diseases, and that's something that I will be taking up with my surveillance and disease control team, looking at what we can do there. And we looked at what the differences are in GP primary care environment in Perth Metro compared to other capital cities, where I think we can say that there is a difference probably in the experience of attending a GP for people living with chronic Hep B in Perth Metro. Okay, that's it from me. I hope there was something interesting in there or useful in all that information for you. Please email me if you have any questions, and if there's anything that you'd like me to explore, very happy to be contacted. Thank you for your time, and I will see you at the next working group on the 29th of April.